I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's guest is one of the best connected people in healthcare that I have come across, meaning he's kind of in the central information clearinghouse, I would say. And we're now after I would call trade show fever. HIMSS flu is over with and Vibe is gone. And now all reality starts to hit with all that connections and all the talk and things like that. One of the things this struck me this year at both of those conferences is the shift in thinking. The fever, I'm going to say fever, most AI in healthcare, but the fever is kind of starting to wane a bit, and reality is setting in about what we can do, what we can't do, things like that. But today's guest we're going to pick his brain a little bit, and we're going to talk about some of that and see where the conversation leads. Today's guest is John Lynn. He is the founder and chief editor at Healthcare Scene, which includes Healthcare IT Today, which is one of my favorite organizations, and Swaay.Health communities. They have publications, podcasts, conferences, video and audio podcasts, and 200,000 followers. So I would call that very, very connected. He also is part of Swaay.Health, which is really the only place where business-to-business marketers and hospitals and health systems can come together and improve patients' lives, which I think is a very, very hefty goal. John also advises healthcare IT companies that can be found on Twitter X, and I'm still stuck on the Twitter handle, at Tech Guy. John, welcome to the podcast.
Yay, thanks for having me. Excited to be on the show.
Yeah, it's going to be kind of fun. So as founder of Healthcare IT Today and Swaay.Health, you've been, like I said, connected, been in this business for 20 plus years. And I was going back through my history, and I've been going to HIMSS for 26 years.
Wow.
It's been a long run.
Changed a little bit.
Yep. No hair. We're not on video, but
well, you've changed a little bit too.
Yeah. So tell us a little bit about your journey, your road into healthcare IT and Healthcare IT Today, and tell us what Swaay is all about.
Yeah, well, to your point, 20 years ago in December last year was the first blog post I ever wrote about EMR. And that was the start of my journey. I'd been working at UNLV in their health and counseling center, implementing their electronic medical record. I'm a tech guy by background. They hired me to implement the EMR for the health and counseling center, really more an ambulatory practice for the students. And I was bored on a weekend and was playing around with SEO and started writing about EMR. Saw that the Google ads clicked and paid a lot more than the other Google ads I'd done before. I was like, wow, this is great. And so I started doing it, big time, made it to the first page of Google for EMR after about 6 months. And fast forward, about 4.5, 5 years later, they said, hey, $36 billion of stimulus for EMR. And all that hard work over years paid off. And I was able to quit the day job 16 years ago. So I've been full-time writing for Healthcare IT Today, and I think we've published 18,000 articles across that time. So just a ton of content over a long period of time. And, out of Healthcare IT Today, Swaay.Health was born. Some of my advertisers came to me, one in particular, and said, hey, is there a healthcare B2B marketing conference? And I'm like, sorry, there's not. I've never seen one. I haven't heard of it. She's like, well, you should start it and I'll be the first to attend. I'm like, okay, it's a good idea. I went to another one, said, what do you think? They're like, oh, when is it? I want to go. I was like, oh, maybe we're on to something. And sure enough, I think it was 13, 14 years ago, we had our first Swaay.Health conference for healthcare marketers. Originally, B2B marketers was where we started, and then expanded to B2C, the provider organizations, hospital health systems as well. So it's been quite an interesting journey over the 20 years, and I've learned a lot. And I would say I've grown into what I deserved. I was on the first page of Google for EMR, and I definitely didn't deserve it at the time since I was so novice to the industry. But I think 20 years later, I feel like we know the industry a bit better and deserve the audience that we have.
Interestingly, that will take that longevity that both of us have been in this industry for a while now. I've noticed in the last, I'm going to say 6 to 8 months, there is shifting going on within healthcare IT. The trends are starting to shift. Um, so you have your own event. I know you've been to Vive, been to HIMSS, like we all have to go to sometimes these days. So I'm seeing this kind of shift. What kind of differences are you seeing over the last several months here?
I think the biggest thing that I see is that CIOs are facing one of the toughest challenges you could have. And that is two amazing forces that are forcing them to act differently. One is their budgets are being restricted. Every healthcare organization is going through some sort of budget allocation, restriction, cost savings. That's just the world we're in right now. Lots of uncertainty, cuttings of reimbursement, employees, supplies, et cetera, are more expensive. So they're going to the CIO and saying, oh, either you're flat or you're cut. So they're having to make tough decisions. And then at the same time, the boards of every healthcare organization is coming to these same CIOs and saying, what are you doing for innovation? So much is happening with AI. What are we doing? How are we staying on top of it? And what are we doing? So CIOs are be like, well, we're going to give you less money. And by the way, we need to take advantage of AI. And in some cases, it's great because AI can save money, and those are complementary goals. But in other cases, you have to spend money on AI to then eventually get to the goals, and that can be a challenging thing. So to me, that is the overarching theme coming out of Vive and HIMSS and the conferences, and even previous to that, probably the fall conferences as well, is these two competing forces are at play, and CIOs are like, how do I navigate this in a thoughtful way?
Well, that's a very interesting conundrum because I came from the rural health part of when I was practicing. I dealt with a lot of rural hospitals. We were kind of a referral center for where I practiced in our group, but had to deal with a lot of, I would call 30-bed hospitals out there. And I've been talking to my friends over the last, 2 years now, and they are really, really struggling. They just exactly what you said. Their budgets are being cut. They can't provide services. But here comes AI, and I love your comment. Let's use AI. Well, okay, let's use a spoon. What are you going to do with it?
Yeah.
So the thing I see, and I love your comment on this, is people say I want to use AI, but there doesn't seem to really be a couple, three or four directions that it needs to be applied to.
Mm.
So what's your thoughts on that?
I mean, I think that is the core challenge because AI could impact everything in healthcare. Like literally, you could come up with an AI solution for almost every part of healthcare. And so I think that's the challenge is they're saying to themselves, what AI really matters, what AI makes an impact, and how can I do this in a sustainable way? And related to that is the question of, should I get AI from my current vendors? Or do I need to be looking outside of my current vendors to get AI solutions because my current vendors either aren't working fast enough, they're not focused on that, they're not doing something, they're not as mature, all of these things. And so I think that is one of the other challenges is waiting for your current vendors to catch up or not. And so, but to your question, the clear winner right now in AI is the AI medical scribe, ambient clinical voice, automating the documentation. That is a clear winner. And we're seeing some interesting. There was a study that said, hey, it only saves the doctor 5 minutes. And it will be interesting to dive into some more of that study that said, hey, maybe it's not saving as much time for the doctors as possible, as what some people are saying. But, that study versus some of the anecdotal experience of doctors who are saying, I'll pay for it myself. And there's, did they measure the cognitive load that's taken off of doctors? Okay, maybe they only saved 5 minutes per patient or per day. That's fine. But if the cognitive load was better and the doctor was able to spend more time with the patient, actually talking with them, and that they enjoy that experience more, hey, that's a valuable thing as well. So anyway, that's one of the clear winners. Revenue cycle management is a clear winner. The problem is there's probably 10, 15, 20 different ways to use it in revenue cycle management. But luckily, we've seen a lot of the revenue cycle management companies offering that plethora of solutions as well. Another area that's interesting that I think is, fascinating for Medicomp as well is on the data side of things. And it's maybe not even so much using the data to then produce clinical results, but it's actually using AI to clean up the data or to make the data more valuable or to apply the data to, so you can understand what is the data mean. So I think that's another one that we're seeing a lot of progress and potential, and a lot of organizations are using it to clean up data.
Since you brought it up, we'll talk about it just a little bit more. There have been billions of dollars invested now in these ambient listening platforms and having them do certain things like that. And you're talking to folks about that. At least I'm going to use some of my own anecdotal evidence. And there now are studies out now that's starting to show that there are errors that are going into the data from these systems because either clinicians didn't read them when they got put in, or they didn't correct them, or whatever. So are you hearing a little bit of that pushback? I know this time savings is there and the cognitive load part is there, but what about the accuracy and actually what gets in your medical record?
Yeah, I think the key thing to evaluate this is that, hey, when we were in paper charts, even, let alone EMR, let alone transcription, any of those, including, human scribes in the room, every one of those had what you just described, which is
Yes,
that
sir.
errors were entered into the medical record.
I
And
agree.
so what's interesting is it's like, hey, are the errors of AI medical scribes, this ambient clinical voice, are they that any different or worse than previous? And from what I've seen, sure, there are going to be some errors. There's going to be people who don't review it. But guess what? There were a lot of doctors who didn't put a lot of information into the chart that should have, or put in the wrong information because they confused patients or whatever it might be, right? Like errors
Hmm.
happened before. And so we're going to have to face the fact that there are different errors. The interesting thing with AI medical scribes, though, is two different things. One is we have the full transcript in many cases, so we can fix the errors. We can see what was said. We can look back and see what happened. It depends on how they're storing them and how they're keeping them. But in many cases, we can go back and see why the error happened. And then the second thing is we can learn from that error and we can improve it so that next time it doesn't happen. And so, or at least put some guardrails in to try to prevent it, or we can work on it. So sure, there are things happening, but I still think it's on par with the previous. And then we have to remember, don't compare AI to perfection, compare AI to the alternative.
Absolutely. And I firmly believe that the ambient listening technology is very, very useful. It has a place. I'm kind of curious about how much it saves folks, but we can debate that. But it's definitely focusing more from a clinician to a patient than a clinician to a screen or a keyboard or something like that, because it takes that kind of burden away. So I'm all for these systems. It's going to be interesting to see, and I've already seen market improvement in those. The
Yeah.
accuracy is better. They're not really good at coding yet, but that's something that we can fix down the road sooner or later. But I do think they're very, very useful. My concern's always been the accuracy of the medical record, as I was when I was head of the Department of Medicine at the U of I. Folks, read your notes, make them right. Don't put them in there until they're done. And that's back when people had pen and paper. So I'll date myself just a little bit. But I absolutely agree. Errors have been here forever. Now it's just a matter of how we fine tune that technology to make it better. Let's turn a little bit to our government. So it sounds like the ONC now is very much engaged in multiple initiatives. Portable charts. I've talked to Amy Gleason now 3 or 4 or 5 times, and she's a friend of mine, so we kind of talk privately from time to time. But anyway, talking about taking your medical record on a QR code, and here you've got it. It's all in your phone. You could give it to somebody and they can unload it. What's your thoughts on what you're hearing about vendors adopting this new level, I would say, of interoperability and portable medical records? And before you answer, there's one thing I will say. Back when I was doing mission work in Kazakhstan, the medical records were portable. They were on 3x5 cards that the patients carried themselves. So they already had a version of this back, and that's 25 years ago. So that's not a new idea, but it's going to be interesting to see. So what's your thoughts on this new level of interaction, which I think is a good thing, but I'm curious of what you feel about that.
I love your example. I often use the example from Little House on the Prairie, and Doc Baker. He had a portable medical record too. It was his brain, and he knew every person there and every clinical condition that had happened. But he also knew the entire body of medical knowledge at the time, which was very limited. So
True,
things have
absolutely.
changed a bit since then as far as the volume of data and the volume of medical knowledge that a doctor needs to know. So it's interesting. I would actually describe what's happening now as it feels like more of the same. It's an
Interesting.
acceleration possibly of what's happening, but and an expansion in the sense of, hey, we want to include more people and let's not rely on government to solve everything. That's how I would describe that tech ecosystem that Amy Gleason talks about in CMS is it's like, hey, let's see what works and then codify it into regulation as opposed to codify it into regulation and hope that someone adopts it. And so I think that's the approach is like, hey, let's do some experimentation, but how do you do that as a government? This is one way to do it and see what moves the needle. So when I look at QHINs and fire and kill the clipboard, all those things, I think it's more of the same. Maybe some acceleration, some extra resources, some focus, some bringing people together to collaborate on some of the difficult challenges. The directory is fascinating. If they can be successful with that, that would solve an enormous amount of problems with what they're doing. So I'm hopeful that they're successful there. As a bit of a controversial take, I'll say the idea of kill the clipboard, the idea of a QR code with your entire medical record, to me, I believe that idea of having a full longitudinal record of you for a patient, I think that's a pipe dream. I think healthcare is so disparate and so, there's so many entities that store your record that I just don't think possibly in my entire lifetime, although maybe after I'm retired, it could happen, but I just don't see it happening. And so I actually think that's the wrong goal. The right goal is how can we share information to improve the care that's happening? Like if we do that, we're seeing that already solve a lot of things. We're seeing people show up to the ED seeking drugs and they're like, wait, you just went to two other EDs or you just went to the one across the way.
Yeah.
Maybe I should ask some more questions. Like we're solving some problems that way. We're even sharing, results around it, right? Or in value-based care, we're seeing this happen a lot. I was talking with Aledade and some of the work they're doing in the way that they're able to, filter up the fact that you had an ED visit or a specialist visit in a hospital 2 hours away, and then the rural health provider that's seen you learns about it because of the interoperability. So we are solving very specific problems, but this idea that I could just have my entire record on a QR code or on my phone or whatever it might be, to me, I think that's the wrong goal. That's, I think, interesting. The other thing that's really interesting that's happening with the government right now that, I think is probably everyone's familiar with it, but I don't think a lot of people realize how impactful it's going to be is information blocking. Like, I think that is changing the narrative for EHR vendors and other health IT vendors about whether they will share data or not. And there's still a lot of work to be done. I'm not saying that they're all sharing, ubiquitously the way that we would like it for patients to be able to get access to the data and other vendors to be able to provide care. But I think the information blocking and even the lawsuits related to it, which is kind of a whole other category of things, like it's forcing EHR vendors to change their tune and to open up in ways that they weren't doing previously. So I actually think that may be the most impactful thing that CMS and HHS are doing right now versus all of the other legislation and efforts that they're working on.
That's a very, very good point. Because I was thinking somewhat of similar things. As an internist, some of my patients had monstrous medical records. They were in the paper world, they were a foot thick. So there's a lot of data buried in all of that. And to have that sent to a person just in bulk, here it is, boom, one class to another. And it's now not about the pipes. It's about the data. It's about how much data, what data is really applicable to what you're looking for, which is another whole concept. So if I'm a cardiologist, I don't really care about, their orthopedic problem that they had 10 years ago, yet it's buried inside that foot thick paper record, or now the bazillion bits of data that are coming over. So I think that's a very, very good point. Really, do you really want the whole thing? And right, exactly.
I would say EHR vendors do want, and doctors do want the whole thing, but they also want AI tools to say what matters to me. And we're seeing an explosion of that, right? There's a whole bunch of tools that are saying that. Even the health data archiving vendors, they're applying that same principle to say, hey, I have this whole archive of information, but what really matters in this current context to this current specialist, that's going to be a huge thing for sure, to be able to go in there and say, hey, what really matters in this plethora of data that you're sharing with me? And we're seeing that. EHR vendors are doing it. A lot of companies are working on that.
Well, interestingly, we'll switch to that in just a little bit, because that's what Metacomp does. We're all about the clinical data, about how you slice it, dice it, organize it, present it, which I think is exactly what you're talking about. And I think as our type of technology or others brings that into the world, that this whole thing of interoperability, the idea of what you just said, do I get it all? Yeah, I get it all, but I can't find anything in it. I'm looking for X, but I can't find it. That will start to get better, and the usability of it will get markedly better, because then you've got focused of your clinical cognitive intelligence on whatever it is you're looking for, which I think is a real key point when it comes to exchanging medical records.
See, and you're right, Jay. Like Metacomp is well positioned to do what I think is going to be one of the most important things in AI, which is the guardrails that we put up around this technology, and knowing what is clinically significant and what isn't, and what's clinically safe and what isn't, and what's clinically valid and what isn't. And we saw that, like, even was it Claude that recently like released their entire packages? You through their tool released it accidentally. There was a breach of all their information. And one of the great insights we saw from that that breach, if you will, is that the reason it's so powerful is the guardrails that were put in place to make sure that bad things don't happen, and that it's used effectively, and that the right information is put. So, the clinical context, the guardrails that we put up, that's going to be the most valuable thing that any AI tool has.
Well, and there's the other darker side of that, where there are people out there saying, how do I crack those guardrails, or how do I take them off to get access to things? So that's the whole privacy and security part of this, which I know the US government's working on. They put out several regulations, but that's one of the things that concerns a lot of the people I talk to, is privacy, and where's my data going, and do I have any say in where it goes? And you brought it up. There are lawsuits now flying around with, you've used my data, you didn't tell me. I know it's de-identified, but I didn't even know it. So there's that whole other layer of things in there that we're going to have to take a really close look at as this really starts to take off. So what are some things that I haven't covered that you think are important?
Yeah, I mean, one thing that I think has been really interesting, and I think there's a phrase coming out of the conferences that I started hearing more of, and I think we're going to hear a lot more of, and that's the idea of AI orchestration. And this idea of saying, hey, I'm going to have multiple AI tools, multiple AI agents doing all sorts of things. And how do I orchestrate that? And am I going to use AI agents to orchestrate AI agents? And how am I going to orchestrate what's happening in my organization? Because these AI tools in many cases aren't solving a problem the way software did before by creating more software for you. What it's doing is it's creating software to use the software that you already have. And that's a very different mindset when you look at implementing a tool. And so being able to orchestrate it as a leader is one thing. And also thinking about how AI is going to orchestrate other AI tools, I think is going to become a really popular term. The other one for me that we kind of touched on a little was, how are we going to pay for all this AI? Right? I mean, this AI
Right.
is not free. And so there has to be some sort of model. And we're seeing really interesting things. We're seeing the classic free pharma advertising models crop up in certain areas. And some people are comfortable with that. Some people are not, depending on how it's done, and sometimes it's embedded in your current system, but that's going to be passed down through the fees that you're getting from that vendor. So, I think there's going to be a bit of a come to Jesus moment, if you will, that you're like, hey, how are we going to pay for this? I've heard, especially smaller medical practices, I've heard them see the AI from their EHR vendor and be like, wow, that's amazing, but I can't afford it. And
Exactly.
hopefully Moore's law kicks in and it becomes so inexpensive that it's not a factor, and that at scale the cost of all this technology approaches zero, right? I'm hopeful that that happens, but right now we're not quite there. So I think that's going to be another discussion that definitely has to happen.
Well, as I think of the billions of dollars that have been invested in all of these systems, that investment is probably going to want to return. So we'll see how fast. And I agree, as it comes down, it'll be much more useful and more broad-based than it is now. But you're right. Who's going to pay for it? When is it going to be cheap enough to actually afford? So you can actually use some of it at scale. So it's a real interesting conundrum here. Billions go in, billions may not come out, and it's going to be an interesting time, really.
Yeah, for sure.
Um, so we're kind of coming down to the end of our time together. I asked this of everyone. If you had a magic wand and could wave it and fix one thing in healthcare IT, it's up to you. What would it be?
That's actually a pretty easy one for me. The one thing that I would love changed in healthcare is the cost. We don't understand our costs. We don't understand why we pay so much for it. And, Mark Cuban has highlighted this so many different ways. And we also see it if we just look at any other country. We pay 5, 10x what other countries pay for the exact same thing. I mean, just even look at some of the markets. I can get an MRI often for $350, and then I pay $2,000 to the hospital. Like, we don't understand our costs in healthcare. And there's a lot of reasons for why costs got all screwed up and why we pay certain things for certain ways in hospitals, et cetera, right? There's politics, there's people chasing money, there's middlemen, there's all sorts of reasons why the costs are messed up in healthcare. But if we could figure out our costs, it would solve so many things. The problem is this, Jay. No one wants to get paid less. At least I haven't found anyone. Do you want to get paid less, Jay? Are you?
No, no, I don't think so.
So it's like everyone's like the costs are unsustainable, and I'm like, that's the most useless comment ever. Because one, what's going to stop them from being paid? As one pharma company corruptly said, no one asks how much it costs when grandma's on the gurney, and they were right. And that's what's wrong with how we price things, is because we shouldn't be profiting off this fact that we are going to take care of grandma when she's on the gurney, right? So, that's troubling. But the reality is this, that, in order to solve this problem, some people are going to have to get paid less, and we're going to have to choose who's going to get paid less. And quite frankly, all of us might have to get paid less if we're going to reduce the cost of healthcare. And that is not a politically attractive topic to bring. If I'm a politician who is the person who needs to, enact the change, they can't go and say, hey, guess what? We're going to pay you less, and, a lot of jobs are going to be cut. And,
Yeah.
there's very few people you could come and say, maybe PBMs, you could say, hey, let's pay PBMs less, and you wouldn't get too much kickback, except from the PBMs, of course. But it's like, who else, like, could you say? Pharma, could we pay them less? Yeah, maybe you could do that, but then you have the whole research angle. Anyway, that's what I would do, is let's address costs. If we could, then our current system wouldn't be too bad.
Well, it's a great answer. And I agree with everything you said. And when you said we don't know our costs, it's almost like airline tickets, where what's your cost of flying from LA to Washington, D.C.? There's a cost involved with that. pilots, planes, fuel, everything. We really don't know in healthcare. You're exactly right. We don't know where our costs are. So we really don't know what the markup is and all the profitability issues that are involved. But you're right. It's not a very politically sound thing to do right now. So we're going to pay you guys less, or we're going to take your part away. That probably is not too palatable given the other billions of dollars that are spent every year in lobbying.
Yeah.
So,
And the other interesting question is, will AI undercut that in some ways? I'm
yes,
interested to see. In
me
some
too.
ways, it's going to undercut some of the healthcare, and it's going to cut off the cost-effective treatments that we do is going to get pushed to AI. And what does that mean for the health system long term? It's a scary prospect, I think, when you look at it that way.
Well, it's a brave new world. It's going to be interesting to see how that journey goes over at least the next 3 to 5 years,
For sure.
because I think it's going to be really rapidly changing. So if someone wants to get in touch with you, how would they do that?
Yeah, well, I like to tell people if you can't find me, you didn't try, because we're pretty much everywhere. But the easiest way to find me is go to healthcareittoday.com to check out our healthcare IT community. Be sure to subscribe to the email newsletter. We do a daily email newsletter, publish a lot of content, subscribe to the podcast. And then for those healthcare marketing and communications professionals out there, be sure to check out Swaay.Health. It's Swaay with 2 A's, so SWAAY.health. Again, we have a newsletter there. It's a weekly newsletter for our healthcare marketing community, podcasts, videos, everything that you want to help improve what you do. That is our goal, Jay, right? At Healthcare IT Today and Swaay.Health, our goal is to provide great information to help people do their jobs better. And, we're lucky to be able to do that because it's one of the most fun things you can do in the world.
John, it's been great. Thank you so much for being on the podcast, and I look forward to future discussions. That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.